Good morning. Welcome to the 9th Scientific Day of MSF UK. Very excited. This is in some ways the 9th, but it's also the first in some ways. It's because what we're trying to do is make this a global event for the first time. We are filming and we are streaming live to research centers, universities, MSFers in their projects all around the globe. And I think it's an exciting way in which, well, to take what we're doing here in London out to the rest of the world. So coming back to my patient crawling under the wire there, I mean, I think the real lesson from this project has got people talking about, you know, it is possible to provide antiretroviral care to people who are going back and forth across borders like this highly mobile population. And at regional level, it's kind of raised these issues that we need to be lobbying for, which is we need the same regimen. And I say on paper we have it, but in practice it's not practically there quite yet. We want the same kind of paperwork in the region, this idea of a patient passport. Every country has its own TB card, ART card, which can be confusing to nurses who see a different paperwork and don't quite understand all the intricacies of it. And also kind of coming back to learning lessons within MSF programmes, I was at a course in Cape Town a few weeks ago and kind of asked several of our kind of programme managers how many migrants do we have in our programmes, and really met with quite blank faces. And so I think it's a question we need to be asking ourselves in our projects is, you know, how big a problem is this, and how should we learn some lessons from Messina in terms of adapting our model of care to this vulnerable population? So I'd like to again thank the Messina team and the people living with HIV in Messina.
A question for Paul from Abby in Geneva. She'd like to know, how do you think we can overcome some of the internal resistance or reluctance in embracing technological initiatives in MSF today? How would you address the issue of confidentiality of medical information, which is one of the common excuses given today in aggregating information?
Well, I'm not familiar with the internal runnings of MSF, but I can understand the question for sure. And I don't know if it's really a reluctance. I think we have organisational models which belong to an analogue era, and I think they really need to flatten out and apply themselves in a much more horizontal digital world that we're in, and collaborate much more with the communities that we are here to serve and to assist. I mean, in my former organisation in the International Federation of the Red Cross and the Red Crescent, there was a huge enthusiasm, actually, and from the highest levels for integrating technology into the humanitarian response and the way of working. But it was still very difficult to integrate that across the organisation because the organisation just wasn't set up for it. So it requires a lot of champions. It requires some, I think, leadership that will take risks. Looking at Mark there, but really leadership. Like I think that what OCHA did was quite brave and quite bold in terms of what they did in the middle of a crisis. And what better time to really learn than in the middle of a crisis? But you have to be prepared to fail and go back to the drawing board and integrate your lessons learned. In terms of confidentiality, that's absolutely key, but I mean, that can be technically overcome. That's not a technical problem with encryption and everything like that.
So I'd like to wrap up with this picture because all thank goes to the staff of the MSF Quetta Pediatric Hospital who worked really hard, and at the end they were really proud on what they were achieving and doing. And I'd like to finish complete with this picture. We had a board in our hospital where every infant and child who was discharged got their footprint on handprint. This board is now full, has been replaced by the second one because our activities continue. Thank you very much.
I just wanted to ask very briefly whether you could place this intervention in the context of existing WHO recommendations, and how closely did you adhere to those, or did you intentionally decide to do something different?
Well, I think what we did was actually we looked at the WHO recommendations afterwards, but I think what comes out of it that different interventions are appropriate in different settings, and if you don't have any primary health care in a place, it's clearly not appropriate. If you have, it should be appropriate. What the WHO says in this Born Too Soon guideline is that we should be looking for new evidence-based interventions, and one of them is offering of the oxygen, supportive treatment for the breathing, and they name continuous positive airways pressure, and they also name surfactant. Like, just to give the context, surfactant treatment costs anything between 250 and 800 pounds per baby. So that's probably not feasible. How, if you compare it with the CPAP, the device which RISE is offering, they say they can put it together for $150 and you can use it for other babies. So yeah, it is in the line, and it might be appropriate in certain contexts.
Okay.
So my name is Anissa Nasser. I'm an emergency medicine trainee. Fascinating presentation. Just in terms of policy change, following on from what you found out now, what is the next step for you guys?
I think, as I was saying, it's a lot more questions have come up, and I think we're now trying to look at a number of different things. One of them being how we can focus more on those who are most at risk. There's definitely a problem of malnutrition. It's just a question of providing let's say, a tool and a model for the government that they can focus on those who need it the most, and then not just step back and say, well, look, the problem's too big, we can't deal with it. So I think that's where we are now.
I want to touch briefly on some new approaches to advocacy. I don't so much want to talk about new approaches to highlighting medical research data, but I'd rather echo the message of the IFRC presentation we had earlier this afternoon, which is that new media is certainly a very, very powerful conduit to giving communities a voice, and that's very much how MSF's been engaging with new media. This is one example of a web-based platform for patients with TB around the world, giving voice to their experience with disease and with treatment in an attempt to raise attention to the need for more treatment.
I would like to just formally thank Doctors Without Borders and MSF. And I want to bring up an interesting tidbit. When I was 16, I emailed the general email at MSF and asked if I could, what I could do in my educational career to be involved with their organization once I graduate, and never received a response. Philip.
So I think it just remains for me to finally thank all of our chairs, to thank you as the audience both here and our online audience, to thank all of our speakers and presenters of posters, and particularly all of those people doing it hard out in the many project areas, continuing to work, to treat, to collect data, to bring questions, and to try and save more lives. So please join me in a final thank you to all of those people.